Good afternoon, everyone, and thank you for joining us for our webinar today. We're very excited to welcome TTU HSC alum, Dr. Ranya Habash, to the program. She'll present today on applications of telehealth and the treatment of ophthalmologic conditions. We reserve some time at the conclusion of her presentation for questions and discussions, and we have a few introduction and housekeeping slides before we jump on into the presentation. I'm joined today by one of our first-year MS1 students.
Hi, my name is Shako. This educational activity is a project of the TexLa Telehealth Resource Center, a federally funded program with F. Mary Hall Rural and Community Health at Texas Tech, HSC, and Well Ahead, Louisiana, with generous support from Telehealth Resources and Services Administration, or HRSA. CME Ethics credit is available for participants of this webinar, and a link to take the survey will be provided at the end of this presentation, as well as emailed to the attendees. These are just some helpful tips for our webinar and for ensuring that you can receive CME credit if so desired. Please make sure that everyone is muted, and please type any questions or comments you may have during the presentation into the chat box. Dr. Mitchell will now introduce our esteemed speaker.
Hi, Ranya. How are you?
Hi. It's so good to see everyone again.
Well, on my screen, it lists me as an amazing avatar. It lists me as David McCartney. I'm not our chairman. I'm the residency program director. So if it lists me as that, I'm sorry about that. But I'm Kelly Mitchell. So I think medicine is a profession of relationships. It's a relationship we have with ourselves, with our patients, with the healthcare organizations that train us, and our colleagues that we work with. And I think telehealth is really going to help us. It's going to expand our ability to have relationships. And our expert speaker today, this is really just a fun day because we're interviewing today, and I can think back 23 years ago. I didn't have the fortune of being here when Ranya was a resident applicant. Dr. McCartney and I think Dr. Gregg are our two faculty that are still here that had the wisdom to bring her into our program. I just had the amazing luck to be a junior faculty when she was one of our mid-year residents. And really, from the moment I think we worked together, we just had a very productive, at that time, maybe a teacher or student relationship. But as you can tell by her impressive CV, she's going to reverse the role today and teach me a little bit. But she was the house staff president when she was here. She had, and I appreciated when she graduated, she had a vision. She said, I'm going to go to Florida and I'm going to make my impact there. And she was in Florida. She's been the president of the Ophthalmological Society of Florida. She's was really, I think, Dr. Alfonso, who's the department chairman at the Bascom-Palmer Eye Institute. For most people who are listening to this, if you're not an ophthalmologist, you wouldn't really understand that one of the centers of excellence, not only in America, but on planet Earth, that is regarding ophthalmology, is at Bascom-Palmer in Miami. And really, Ranya's filled so many interesting roles there. I mean, and I'll read a little bit because I can't keep track of it. But really, I mean, she's done comprehensive work, cataract surgery. She's their technology person. She's their engagement faculty member. But always looking for ways to expand the relationship component of medicine. And so let me hit a couple highlights here. And Ranya, I'm sorry I couldn't commit these all to memory, but I mean things like being recognized as a young star in ophthalmology, being the CEO of Lifelong Visionary Innovation Mentor at Stanford University, right? The director of technology, as I said, at Bascom-Palmer. This one I like because the founder of HIPAA-Chat. I've known Ranya through the years, and she has this just inexhaustible, positive energy vibe. I consider myself a relative optimist and a high energy guy, but Ranya's just always been that person that's really just generates that. She's been in Becker's Hospital Review of Top Healthcare Entrepreneurs, and I think the telemedicine training. I mean, she's been involved at some of our highest level of government regulation, Senate stuff. She's worked with some pretty heavyweight companies, Microsoft, Amazon, and really just things that we need to have. But really more than anything, she's been a part of Texas Tech's honorable past. And I think what touches me the most is that today I'm interviewing, hopefully being able to find maybe this year's version of the Dr. Ranya Habash to maybe join our residency next year. And so without much more, I think I'll turn it over to Dr. Habash. And Ranya, thanks so much for spending the time with us.
Oh, Dr. Mitchell, that was so nice. I don't even know how to follow that. I credit you and Dr. McCartney and the rest of the staff there at Texas Tech with who I am and how my career has blossomed. And it certainly has. I've done some things that, we don't get to do a lot of times. I'm really lucky for that. And another really, really huge mentor who's joining us today is actually Dr. Alfonso. He's the chairman at Bascom Palmer. My quick introduction of him is he's like the undisputed heavyweight champion of the world at Bascom Palmer for the past 20 years or so. So to have him as a mentor, as well as you, Dr. Mitchell, Dr. McCartney, Dr. Greg, it is a real honor to be here. And Dr. Wilson also. It's so funny how all of us are coming together like this. But with that, I know Dr. Alfonso has to run to another meeting possibly, so I want to give him the floor. He wanted to say a few words as well, if that's okay.
Well, thank you, Ranya, and congratulations to Texas Tech for having put out such an incredible individual as Ranya is to really help so many patients. And ultimately, I think Ranya expresses the leadership role that I think all of us want to see in every human being, and that's to be a servant leader. And Ranya, as such, everything she thinks about is not about her, but it's about how can we improve the life of someone else. And I think that as you meet today and discuss telehealth, telehealth is all about that. It's all about helping create access to patients and non-patients who need improvement in their care, and how to improve quality and outcomes of eye care. So if you think of those three things as the goals and use telehealth as the strategy to reach that goal, those three goals, then I think you're going to get something good out of this. And for me, this is what Ranya is all about. And I think that the more we talk about it and the more we make sure we continue to work in this area, I think the better is going to be the improvement in what we can all agree is a broken and very expensive healthcare system, which is what I feel responsible for having created during my lifetime, because it's somewhat what we've been supporting from 35 years ago when I graduated from medical school. And it's time to keep working towards helping improve this broken and very expensive healthcare system. And I think as I see your outreach, Texas Tech is just an incredible institution that has the ability to really make an incredible paradigm shift in eye care in your region and nationally as an example. So can't wait to listen to the recording. And I apologize, we have an ongoing meeting here in our auditorium on ocular surface diseases, and they're waiting for me to join a discussion group. So I'm going to have to listen to the recording, but I'll stay on for a few minutes. Thank you so much, Ranya, for giving me this opportunity.
No, thank you for being here and supporting it. So what you all are going to hear here is probably something you've never heard before when it comes to telehealth. I mean, you'll hear some visits, you'll see some examples of visits, and I wanted to be really practical and concrete about the things that we share. Dr. Alfonso was totally instrumental in helping implement all of these technologies during the pandemic. But the really cool thing is that they've persisted since that time. So I'll give you some of the latest numbers and statistics and visit types that we're doing still at Bascom Palmer, and that we proliferated really worldwide to share our experiences with other institutions around the world. And I'm really happy actually that you all reached out to me to do this, because, you know, being at sorry, I'll mute myself here, because being at Texas Tech, I mean, our catchment population was over like 6 hours, you know, and we saw patients from Oklahoma and Arizona, and there is really no better use case for telehealth than at Texas Tech University and all of its subsidiaries and other campuses. So hopefully this will be a really easy, practical way for you to see some of the things that we've implemented at Bascom and also at other places around the world, and share best practices. And afterwards, of course, you know, we definitely want to leave some time for some good dialogue. So with that, let's get started. Ready to go? Is everyone ready to go? Yep. Okay, good. Got the thumbs up. All righty. I'm going to start with my favorite slide ever. And this is also Dr. Alfonso's favorite slide, I think. This is a picture of the Jetsons from 1962. Does anybody remember the Jetsons? All right. Well, the Jetsons was way ahead of its time. It is literally showing a telehealth visit here. I forget the kid's name. I think it was Elroy or something like that. But this is in 1962. And it's amazing that it took us this long to catch on and start doing telehealth ourselves. But I love starting with that slide. And, you know, like I said, that's Dr. Alfonso's favorite slide as well. Let me start here with the Press Ganey scores. So we're going to go first with some, you know, housekeeping stuff, just so we kind of set the stage here. But in the Press Ganey report, it showed the key takeaways, which were, there were positive ratings for, you know, all of these teams, but basically the likelihood of recommending a doctor who performed telehealth was higher than those who don't perform telehealth. And I think that's really important, because you want to make sure that you are performing for your patients and giving back what they're looking for. They're looking for doctors who are more technologically advanced, more tech savvy, people who have a newer way of thinking. And so it's really funny, actually, that when the pandemic hit and we saw these Press Ganey reports come out, all of our ratings were super high for telehealth, and the patient's likelihood of recommending was so high. The other interesting takeaway is that the average age for telehealth was like 54 versus 58 for a regular visit, meaning there was really no skew towards younger patients, which what we thought was going to happen before. And definitely now I can tell you, you know, my 90-year-old patients are still actually like asking for telehealth visits, and they're really used to doing it. So, you know, just wanted to set the stage there for you. During the pandemic, and again, I'm going to start with that only because that was really kind of the impetus for the growth and the explosion in telehealth. But I want you to keep in mind, this is not just pandemic telehealth. Everything I'm going to show you here, it has persisted and actually accelerated since that time. But during these times, you're going to see these were the number of telehealth visits we did. This is from Medicare, actually. These are Medicare telehealth visits before the pandemic, right? 0, almost nothing. And then it shot up, and then it sort of normalized. And everybody said, oh, you know, the rate of telehealth is decreasing. Well, of course it's decreasing, because it was at an all-time high, and that's all anybody could do. So, you know, one of the common misconceptions is that it's got to be telehealth all the time or nothing. And we know that's not true. It's just like anything, you know, it's another tool in your tool belt, and you have to, it's augmenting regular visits as well. But interestingly, this is our graph at Bascom Palmer. So 0 visits all of a sudden shot up, and then it leveled around this area as well. So it's really funny how it paralleled the Medicare chart. Now, this is the really cool thing. And these are the latest statistics. Okay, this is fiscal year 2024. Look at the telehealth utilization we have at Bascom Palmer. So it actually grew after the pandemic. And it's at this all-time high for 2023. Of course, 2024 is, lower because it's not the full fiscal year yet. We don't have all the numbers in, but look at this. I mean, it persisted and actually accelerated after the pandemic. And so I think that's a really important thing. I mean, we've done 21,000 visits here. So this is insane. So again, I wanted to drive home the point that, this is not a nice to have. I mean, this is a real adjunct to clinical care. And I'm going to show you some really practical examples of how it can be used. I want to make sure that people stop me if they have any really burning questions, because I really do want this to be kind of a dialogue and have your participation as well. Okay, so lessons learned, best practices. So these are things that we collected from, not just from Bascom, but all over the world, okay? So number one, make sure you engage your office staff. We don't want Dr. Mitchell to go in by himself and try to do a telehealth visit and, help a patient download Zoom or whatever. That's not his job, right? So we want to use our office staff, and that's a really important point here. Your office staff really should be doing everything they would normally do to prep a patient. And you come into the room and do your visit, or come on the call and do your visit, just like normal. In fact, that's number 7 here, which is follow your standard operating procedure. And that includes all your tech and scribe workflows as well. The other big no-no I see all the time, definitely try not to mix telehealth and regular inpatient visits. That just doesn't work. It's kind of like trying to do cataract surgery and LASIK surgery on the same day, like in between each other. Somehow the mindset is not there. So, what we've really tried to do is to advocate for like telehealth only mornings or afternoons or whole days or whatever, so that everybody's just in that mindset of doing telehealth and not mixing. You can use any HIPAA-compliant software. There's a million different things out there now. Here at Bascom, we use Zoom. It's interfaced with Epic. Microsoft Teams is another HIPAA-compliant one. Doximity is an excellent one. Disclaimer, I consult for Doximity. I'm an advisor, so I have a little conflict there, but it is an excellent technology if you've never used it before. It's great, actually, because it sends the patient a web link. Instead of having to download an app. And it also pings you when the patient is ready, and it also pings the patient when you're ready. So the patient doesn't have to wait on hold. You don't have to wait on hold or anything like that. It's actually a really nice system, but we use all of them. Messaging is critical here. Your staff has to be trained. It needs to be, at Bascom, when we were setting this up, we did have an issue at first with people saying, oh, well, we're not really sure, if you'd want a telehealth visit, but if you want one, I guess we can offer it. The staff needs to be scripted to say, hey, guess what? You're in luck. We offer telehealth visits now. And, anything that we need to bring you in for, we still can, but this will now enable the doctor to be able to triage you or to see where best to send you next or whatever, So it has to be really uplifting, positive messaging. The patient registration and consent say, great news, your doctor now offers telehealth, which is a nice way to start. Another thing that was really important, when I do a lot of the telehealth visits, I'm at home on a different campus. I'm not really there, with the rest of the team. And so doing group chats with your team is really important. It's kind of like, having air traffic control and being able to steer which patient you go to next, and in which order, and what patients need help. And, it's just basic communication. And a lot of people just forget that step in the process. Like I said, follow your standard operating procedure. This means that your tech should still get on, the phone or the video call and start working up the patient. Why are you here, Mrs. Simpson? What's your chief complaint? Your history, present illness, go through the medications, the allergies, all the normal stuff that the patient would normally have done if they were in person. And then you also document just like you normally would in your EHR. Now, we have virtual scribes as well, and there's a really nice opportunity for ambient scribing too. And I like the scribe workflow. I think that it really improves the the FaceTime with your patient helps you concentrate on the patient rather than trying to concentrate on documentation. And then the documentation is way better because somebody else is, doing it ambiently too. So I would highly advise that. Even with telehealth visits, you'll see in these next few examples, we had a virtual scribe on the call with us the whole time. And then e-check-in always streamlines things. Okay, so again, this was like a lot of housekeeping, but now we get to the really fun stuff. And the main example, or the main message here is keep it simple. It's the first thing we learn in medical school, and it still holds true here. All right, what are the best use cases for reimbursable telemedicine? Because nobody wants to do anything for free, right? We get that. So we want to make sure that all the visits that we talk about are actually reimbursable. I will go through medical student teaching and things like that at the very end, but for the most part, I mean, these are all reimbursable visits, which is a really important point. That's what stops a lot of people from doing telehealth. They think they're not going to get paid for it. And yes, there are a lot of different rules, and the rules have been changing. State of Texas is difficult, state of Florida is difficult, but as long as you follow the rules and you understand them, then yes, you will get reimbursed. And most times it's exactly the same as an in-person visit too. So you're not taking a hit in that respect. So this is the whole list of visits, and I'll go through them all. When we did this, we actually put together a global collaboration with all these different institutions where we were all sharing best practices. So a lot of these pearls and tips that I'll be sharing with you are coming from other institutions as well. All right, we're gonna get started here. So a picture's worth 1,000 words, right? We all know that. And actually another really important point before I jump into this is everything that I'm going to talk about, it is all applicable to general medicine, not just ophthalmology. So I'll use a lot of ophtho examples, but I want you to take away that this is for everybody. The codes are the same. They're just E&M codes, right? So all of these procedures and protocols are applicable across medicine. We don't even use I codes really in telehealth. We're still using the E&M codes, and all of these things apply. So I'll use the ophtho examples, but just so you know, I wanted this to be totally applicable for everyone. So that's the take home here. Okay, pictures worth 1,000 words. I'm not sure if Dr. McCartney, Dr. Mitchell are still on the phone, but if we have any ophthalmologists here, any ophthalmologist should be able to answer this picture. There's one patient who gets to stay home and use artificial tears, and there's another patient who needs to go straight to TTU HSC Medical Center immediately. Do we have any ophthalmologists on the call, or anybody who wants to take a guess?
Our medical student says the one on the right.
Possibly.
Yeah, the
We're
one.
guessing.
Yep, you got it. The one on the right has to come in. So the one on the left here, it's just conjunctivitis or pink eye, right? So you don't even want them in your office. You actually want them to, and they don't feel like being there, right? They want to be home using artificial tears. And here you see the iris is actually prolapsed, and this is a ruptured globe. So it needs to be operated on immediately. Well, you just did telehealth, okay? And you're a medical student, right? And you just triaged an ophthalmology patient. That's pretty cool, right? And so now imagine you're in Texas and you've got this patient who otherwise would be ambulanced in from 3 or 4 hours away for the patient, for the eye on the left, the conjunctivitis eye. And that happens all the time. So now think about like healthcare dollars that are wasted, the inconvenience to the patients. We have patients helicoptered in from the Caribbean, Bahamas, whatever, all the time here to Bascom for stuff like this. The opposite is true too, though. There's many patients who don't think the picture on the right, the ruptured globe, is an issue to worry about. And so they stay home and don't seek care. And guess what happens then? Dr. Mitchell knows all about this. Then we have really bad stuff happening in the eye. And that's exactly what we're trying to avoid. So with this simple picture, you are now triaging that patient within 30 seconds and being able to determine whether one needs to come in through an ambulance from 3 hours away, or if they need to come in immediately and not wait that 3 days instead. So really, really important. I mean, this is probably one of the most important visit types. And I think Texas Tech and its surrounding areas, its catchment population, all its facilities, this is so perfect for you guys to do. This is going to change lives. We have any questions yet? Okay, so I wanted to share some statistics from what we call it our rapid virtual clinic. This is just virtual urgent care. So after the pandemic, we started implementing a virtual triage center. At Bascom, we have one of the busiest ERs in the world, probably. We see like 100 patients a day. These are just eye patients. And like I said, they're like ambulanced in or helicoptered in from all over the place for things that they really don't need to come see us for. And then they're trapped there in Miami, right? They're sitting there. They don't have a place to stay. They're there overnight. I mean, it's a horrible situation for everybody, not to mention the healthcare dollars spent. But look at these statistics, okay? This is from our rapid virtual clinic. This is just as of last week, the numbers. The amount of new patients that we're seeing through this clinic, and by the way, it's self-scheduling. So patients just get online, they self-schedule in our virtual clinic, and we triage them from there. We have a team that's triaging them like between, I think, 8 a.m. to 4 p.m. And we're thinking about extending it now because every slot is taken all the time. Our new patients, 85% of new patients. So talk about new traffic to your facility, right? These are all patients who have never seen you before, but now they understand that you have this rapid virtual clinic that you're offering for them. I mean, that's a huge win for the health system, right? Established patients were 15%. Age range was 4 to 92. We're not excluding anybody. Even babies. I mean, we have seen babies before. It's not in this number, but this is totally amenable for patients of all ages here. I think this is the most stunning statistic that I have ever seen in my whole life, okay? 96% of the patients we're seeing never need to come into the ER. I just want that to sink in for a second. Just imagine if all of our insurance payers heard that number, okay? All of those patients did not need to come into Bascom Palmer and sit for 4 hours and see a specialist and have all that time and expense and inconvenience. It's unbelievable to me, you know, all the healthcare dollars that we can save here, not just healthcare dollars, but obviously it's much better care, right? 96% never were brought into the ER. They had stuff that we could deal with on the outside. That's so important. Does anybody have anything to say to that? Because I think that is just a drop the mic moment.
It's a great data set. It's a great point of data there. The other thing to look at is are all of these patients, are they patients from Florida, or is this geographically over a larger area?
So it's funny you mentioned that, you know, so when we first started the clinic, this was geographically all over the place. Like I said, you know, we get patients from even out of the country who are flown in to see us all the time. And so this was open to everybody. It is open to everybody. Now with the latest telehealth pullbacks, which we couldn't stop, it's really egregious, but Texas and Florida both will not allow you to see a patient across state lines anymore. And so, you know, it's still, look, Texas is a big state. You'll still have plenty of opportunity to see patients. But, you know, obviously it's so much better for everyone if you don't have to transport patients across state lines either, and you can do this that way. I'm still hopeful that this will change, be overturned eventually. But for right now, you have to stick with Texas and we have to stick with Florida. Unless there is a caveat, and I will tell you that here in a minute. I almost forgot about that. Okay, moving on. So this is all the workflow, the boring stuff, but it's the protocol that we developed from step to step, like how a call is triaged and who triages it and where it goes and, you know, from there. And so I will make this available for everybody so you can you don't have to reinvent the wheel, just use this or, you know, modify it however you'd like. Okay, moving on to the second visit or to the next visit type. Everybody still with me? You good? Okay. All right. So telecounseling. another one of my favorite types of visits. In ophthalmology and in many other fields, genetics, counseling, oncology, we're spending a lot of time going over lab results, x-rays or imaging results with patients, going over their treatment options. That takes time, right? What we found is that when we're doing this cataract counseling or refractive counseling for LASIK or some of these other things, also for uveitis, ocular oncology, genetics counseling, all of these things, we started doing it. This, again, it's during the pandemic, but it has persisted now. So we started just doing at-home visits so that the patient could be at home and we could do telecounseling. And this is time-based. This is a time-based visit. So if you spend 50 minutes talking to a patient about their oncology options, how you want to treat them, and you have all these questions, you're going to get paid based on time, right? That's the E&M code level 5. So you actually get paid for the time you spent, which I think is really important here because you want to spend time with these patients. But more importantly, guess what happened? Patients said, oh my God, this is so great. We don't have to wear masks because we're at home, right? And you're at home. And they said, this is more personal than an in-person visit. Again, really important. I mean, I got to meet patients' dogs. They were sitting in their lazy boy chairs while we talked. But the really cool thing here is that their families were with them as well. Even if they weren't at home, you can see from this picture, there's me. This is my patient here. His wife is with him. This is their daughter and their grandson. And this is their son who's in another state. Everybody's in a different place, right? But now they're all in the visit. And when you have a patient in your exam room, it's just you and them. And they're taking in all this really important information. They can't synthesize it. They're already stressed. They're already tired. They're probably hungry, diabetic, whatever, and they can't synthesize that information. But now when they're at home with their dog in their lazy boy and they have their, neighbor come by to listen to the visit or whatever, it's a complete game changer. And what we saw as a result was that our cash pay services went through the roof. We didn't expect that to happen. We weren't going for that at all. But all of a sudden, people started getting, the premium IOLs, intraocular lenses, or they started getting the cash paid procedures. They started signing up for LASIK more often. And it's because they just felt so much more comfortable and so much more informed. So this is a better way to treat patients, and you get paid for it too. I mean, this is another just critical visit, I think, for everybody. All right, moving on here to doctor consults. All right, I wish, I'm not sure who else is on the call, but I know there's plenty of doctors out there. How many times do you all curbside each other about a patient? Because you're concerned, because you're good doctors, because you just want to get another opinion, right? That happens all the time. We spend a lot of time on that. I mean, our message boards, our WhatsApp chats are on fire all the time, asking about patient situations, getting everybody else's take. Well, what if you could get paid for that? You should get paid for that. You deserve to get paid for that, and you can. There are codes that will allow the consulting provider and the referring provider to actually get paid for this kind of co-management model. This is collaborative care. It doesn't have to be done on the spot. In this picture, you'll see me. I'm in the ER with a patient. That's my virtual scribe. But this is Dr. Alfonso. And this was a patient who had a corneal issue that I really wanted to run by him. Dr. Alfonso is a busy guy. He's to get an appointment with him, it's 6 months. Instead of having to wait that 6 months, I asked the patient, would you like me to just try to get my chairman on the call, and we'll try to do a quick on the fly curbside consult for you. Patient was like, doctor, that is the most amazing thing I've ever heard. So now you're a hero to these patients. And it doesn't have to be done on the spot. You can also say, I'm going to call Dr. Alfonso after this, and we're going to go over your case, and he's going to give me some recommendations. I'll call you back and let you know what he says. You see, so this type of service is so important for our patients, but it's also important for us. I mean, we do this all the time and we're not getting anything for it, but patients are more than happy to pay for this. And it's actually, it's a covered service under their insurances. They have it. And again, it just decreases your time to seeing the patient. It's so much more efficient. And this is almost like a concierge level service for patients. It also will allow your doctors to keep their own patients. So thinking of a place like Texas, if you're consulting with a patient or with a physician in another facility across the state, for instance, right? That patient doesn't have to come see you and spend all that time, and you're not stealing that patient from, the referring doctor. So this is a really nice way for both sides to do a really good service. Okay. I know I'm going to sound like a broken record here, but like every visit is like my favorite visit ever. This is another one that really is close, near and dear to my heart. Second opinion consult service. Okay. I think we just talked about, the fact that in Texas, you are now stuck with seeing patients only in Texas. But hey, Texas is a huge state. There's plenty of patients from 6 hours away who still need a second opinion consults, and the same with Florida. And I'll tell you at the end here a way to not get around this, but to make sure that this is compliant. So why do we do second opinion consults? Okay, or how do we do it? Let's do that first. Okay, so the patient makes a request. The second step, and then that's important, the patient has to request. You can't like reach out to a patient and say, hey, do you want my second opinion consult, right? The patient has to request it. So you put this online, you put this, in your messaging, in your advertisements online, on your website. The staff makes them the appointment and then obtains the medical records from whomever else it is, okay? Payment is time-based, again, E&M or cash pay, as long as you have an exclusion of benefits form. The physician then reviews all the records and performs the video visit and goes over everything. Now, at a place like Bascom, we are like #1 in the universe for the past 20 years, like I was saying, right? Everybody wants a second opinion with us, and everybody deserves one, even if they're in Zimbabwe, right? And they can do that now because of the service that we've put in place. These patients may never have had the opportunity to see a great, like, this is Dr. Harbour down here. Dr. Harbour is the head of oncology at, I think it's UT Southwestern now. So he's down in your neck of the woods. He was at Bascom before. He's one of the world's greats at ocular oncology. And these patients are privy to him being able to consult on their cases just with a video visit. It's amazing, right? The other really cool thing that we did was we started inviting doctors from the other side of the world, to join us. And so it was a teaching experience as well. So here, what you're going to see in this picture is me, because I set up the visit. This is our virtual scribe. This is Dr. Guillermo Amescua. He's a cornea expert. He's amazing, otherwise known as Cornea Puppy, but he treats all these really rare diseases that Dr. McCartney will appreciate, things like acanthamoeba, fungal keratitis. And so he is very sought after in the world. Now, this patient was in Saudi Arabia. He and his mother are here. And it was also an ocular oncology case. And so we got Dr. Harbour and Dr. Amescua to both consult. This is his physician in Saudi Arabia. And he was on the call as well. So now we're teaching a man to fish, right? And we're like collaborating with our colleagues all across the world. This is not like we're doing something better than someone else or another doctor. We're augmenting their care and helping them care for their patients wherever they are. This is less costly for patients. It avoids unnecessary travel, and it helps patients in underserved areas access tertiary level care that they may never have had before. I'm going to show you one of the most heart-wrenching videos here in a second. But before we do that, how I mentioned before that now that Texas doesn't allow visits across state lines, that's a real blow to telehealth. However, you can use third-party services for telehealth. And the way this works, it's almost like you bill under another provider's name who is licensed in that state where you're seeing the patient. So, and actually I should backtrack a little bit on that. It's not that you can't see patients across state lines. It's that unless you have a medical license in the state where the patient resides, then you can't. So if you have a medical license in that other state, no problem, okay? But if you don't, then a third-party service is actually a really nice workaround. You bill under their name and they're the ones licensed in that state. This happens all the time for nurse practitioners, for instance, right? So it's no different at all. But this is the way to get around that caveat. Okay. Okay, not sure why it's not advancing. Okay, there we go. My second opinion protocol, again, I'll share it with you. It's the boring stuff. But this is one of the most impactful videos you're probably ever going to see. It's like 2 minutes long, or 1 minute long. But this is Dr. Nina Barakal. Dr. Mitchell knows her. She is one of only like a handful of pediatric retina specialists in the world. People would never have an opportunity to get to see her for their kids. And because of what we've done with second opinion consults, now it's making it possible. So this is Dr. Barakal and I, and Dr. Jackie Kovac, who's another retina specialist. We're being interviewed by the media.
Well, there's nothing, there are a lot of mothers in the audience, and there's nothing more, devastating for a mom to have a child that's sick in whatever way they are sick. And vision in our world is so critical that, there's nothing more strong or, I have mothers in the world that have, given everything and to take a flight to get to Miami in the past. So, like they gave their car, their house, everything just to come and have an opportunity for their kid to potentially have a vision saving surgery. But now with the way we're doing things, it's like, you can have anybody in the world reach out to us and you give an opinion. That is so powerful, for women everywhere, for patients everywhere. I mean, you simply with a computer, with a phone, wherever you are in the world, you can connect to one of us. That is very powerful.
Oh, it's absolutely remarkable. It basically changing lives from someone on the other side of the world because of telemedicine is incredible. Kudos.
Amazing, right? She's not exaggerating. People sell their car or their home just to come to Miami to get an opinion from her. Anyway, I literally started crying when she was talking there. So it was a little embarrassing, but it still gets me every time. This is the impact of what we're doing. This is the power that we hold in our hands. And that's why I feel so passionate about wanting to be here with you today and share these experiences. Okay, so telestaffing and video slit lamp exams. Now, this really only applies to ophthalmology, but the hybrid visit, which I'll talk about here in a second, is really for everybody. We used a slit lamp adapter that was like $250. I have no financial interest in it. We put it on the slit lamp, and people are able to follow along on the visit and watch it. And that brings us to hybrid visits, which can be done across any specialty. But this is really a nice, easy visit, especially in Texas where you all are. I'll use another glaucoma. I'll use an ophthalmology example, right? We have plenty of times where we have a patient that we put on medication for glaucoma. They need to come in for an intraocular pressure check. That check takes like maybe 15 seconds if it takes long. So instead of coming there and making an appointment and sticking around all day just for that quick check and a visual field test, for instance, we are now doing things where we're splitting the visit. So a patient can go anywhere to get that testing done, and then we follow up asynchronously to go over the result. Does that make sense? Are you all already doing this? Because a lot of health systems are. Anyone? Okay,
yeah, I can't speak to specifics. I know that there's some of this going on with different, I don't know about our opto, but I know this is really popular everywhere, this sort of a hybrid visit, or it's just partially asynchronous. This is a very popular way that we're seeing a lot of telemedicine, not just in Texas, but everywhere.
Perfect. Okay, I'm so glad then. I won't spend a lot of time on it then. So obviously way more efficient. Patients can be seen at any campus. It's really perfect for your catchment population. We even started like after hours and weekend visits because, we're not there. So we can extend the visits actually, which is more convenient for the patients. And then for billing, you use the same E&M code that you would as an in-person visit actually, as long as, you follow up within that 24-hour period. Okay, so it's the same date of service. All right, here's a quick example of a video slit lamp exam. Actually, I'm gonna just move aside from that because you all are already very familiar with that. I want to make sure we leave some room for questions. Okay, remote patient monitoring, another really great visit, okay, that is very underrated, actually. So remote patient monitoring is kind of a moneymaker for your practice, like for the health system, and it's very underutilized, but you can do this with like blood pressure, blood sugar checks, let's see, orthopedic stuff. But here in ophthalmology, we can use it for visual field testing, for macular degeneration, like Amsler grid testing, for IOP checks, intraocular pressure checks. But that one requires a machine, which I can go into the details about later if you'd like. In any case, this is the billing that goes along with remote patient monitoring, okay? You get a fee for setting up the patient from the beginning. Then you get a fee if you use a device, and even software as a medical device is what counts. So as long as you have software that monitors a patient, then you actually get paid $62 roughly. I mean, this is our local codes. I'm sure it's not that much different in Texas, but this is how much you get paid per month for the device. To monitor the patient, another $50 or so for the month. Now, what that means, what monitoring means, is that you should look at the results that are coming in for 20 minutes cumulative time per month. And that can be by any billing provider. It doesn't have to be the physician. The physician just has to have some sort of exchange with the patient to say, hey, I like those numbers. You're doing great. Continue present management. And that's it. Check that box. And that's RPM. It's kind of amazing, right? But, you know, I know I'm spending time on billing here and coding, because I do think it's important for all of the doctors to understand they actually will get reimbursed for this stuff. But on the flip side, you know, from the patient side, this is way better for patients. I mean, this is preventative care. We now are alerted whenever something is out of range. We're setting parameters. So imagine now you send a patient home with a blood sugar monitor, right? And you've set now their parameters. You want it to be between a certain range. If that number is outside of a range, you're going to get alerted. You're not alerted every time they check their sugar. You're only alerted for the stuff that you need to take action on. And I think that's really important also to note. So I'll show you an example. This is a beautiful example here at Bascom Palmer of remote patient monitoring for glaucoma, but please keep in mind, this is for anything all across medicine.
When Ranya Patel was born, her parents were shocked to learn she had primary congenital glaucoma, a condition that could cause blindness.
In the hospital, her eye was completely gray, left eye, and we didn't know what was going on. And the doctor said, you know what, go to Bascom Palmer.
That's where Dr. Alana Grajewski, an expert in pediatric glaucoma, told the Patels this was very different from the disease that adults get.
Children with glaucoma require surgery, and often urgently. And it is one where the price is high if it doesn't happen at an appropriate time.
So the glaucoma is in both eyes, but it was very, very obvious in the left eye, and she has, very limited vision in that eye.
Ranya had surgery when she was just a few days old, giving her a 90% chance of better vision. Now, at age 14, new technology is allowing her to monitor her eye pressure at home.
A probe looks like this. So the small white ball at the end is what touches your eye and collects your eye pressure. Like this.
She then uploads the information in real time to her doctor.
I'm able to see Rihanna's pressure at times of the day that I otherwise never would. If I do not want the pressure to be above a certain number, if it is above that, I will be sent an alert.
This integrated system is changing the way doctors at Bascom Palmer care for their patients.
We've figured out how to put all these moving parts together, and it's really resulting in some excellent charting of how a patient's pressure fluctuates with the day.
Saving Rihanna's sight as she grows.
It's like the best way to be able to fix and treat your eye.
I see you all smiling over there. It's so cute, right? And
when Rihanna
makes perfect sense. All right. Very last visit that I'll share with you here, and then we'll talk. But this is for post-operative care. Post-operative care is like the easiest thing in the whole world because it's a global visit anyway. You're not getting paid for this visit. Patient doesn't feel like coming in the day after surgery, and you you oftentimes don't need them to come in, right? So this is a very, very well-known ophthalmologist in our field. This is Blake Williamson, and I was going to show you just an example of how he does his post-op visits, because it's really good.
Dr. Williamson here at Williamson Eye Center. I'm going to show you my, hey, it's Dr. Williamson here at Williamson.
I'll just forward a little bit here. Okay, so here's what it looks like. Now, some would say he's doing it wrong because he's actually in the office, but he's seeing other patients. That's why he's there.
Patients are already in the virtual waiting room here. You can see all these patients are all the cataract surgeries. Did about 25 cataract surgeries yesterday. So instead of them waiting in the waiting room, they're right here in the virtual visit. So we're just going to go to the very first one. Can you hear me?
Yes, I can.
Okay. How you doing? Everything okay? I'm doing fine. Thanks for allowing me to share this with my colleagues to show them how to do telemedicine. I'm doing okay.
Hey.
No eye pain or anything?
I'm sorry.
No eye pain or anything? Okay. Let me take a look at that eye that I did yesterday. Bring it real close to the camera, please. Good. I want you to look up and to the left. Right? Perfect. Fantastic. So everything looks good. So the cornea is nice and clear. The pupil is round. Everything looks excellent. You're doing very, very well. So I want you to continue to take all of your post-operative drops. And as long as you're doing well, we'll see you in clinic next week. They'll give you a call and let you know exactly when that's going to be. If you happen to have any redness or loss of vision or eye pain or anything over the next 3 or 4 days, I do want you to come on in right away. But I don't expect that. I expect to see you at your normal scheduled appointment next week, okay? All right. Hey, how are you?
Hey, Doc, can you see me okay?
I can see you just.
I'll stop it there. All right. So I'm sure Dr. McCartney is going to have some questions about that. But the point is, post-op visits, I mean, unless the patient is like doubled over, nauseated and vomiting and telling you their eye, feels like it's going to fall out. Most of the time, it's kind of an unnecessary visit, and it's really only necessary so that you can reassure the patient more than anything. So that 1-day post-op visit is actually a really nice visit. And now think about ortho. I mean, my God, just think about these orthopedic patients who have to like limp into your office the next day. There's so many opportunities for doing this just virtually instead. All right. This pretty much brings us to the end. I just wanted to spend a second here on population screening, because I do think autonomous AI is going to be, going to emerge as even more important in the very near future. I'll share this really quickly here. When we did, this was not autonomous. We were actually doing a reading center at Bascom Palmer, but the numbers still align. When we were trying to do screening for diabetic retinopathy, our screening rate here in Miami was 40%. We all know everybody on this call knows you need an eye exam every year if you're diabetic, right? You need a screening eye exam. Well, we only had 40% screening in downtown Miami, which by no means has like a lack of ophthalmologists or care. But because we were putting cameras in the primary care offices and doing screening there instead, we increased the rate to 82%, which is huge, right? We also, though, found 50% pathology. 50% of pathology that patients didn't even know they were walking around with. And we caught it because of a simple picture. Okay, that's amazing. We were also then able to expedite those patients for follow-up, so they weren't waiting for months to get in to see us. And then the retina specialists, for instance, were really happy because now they got actionable patients rather than just rule out or normal screening patients. So it's a win-win for everybody across the board. And then, I mean, I don't have to drive home this point. I mean, the whole reason we're doing this is to catch patients before they develop irreparable disease, right? So anytime you can intervene earlier, you're doing that patient a huge service, and not just the patient, the entire health system. So I feel strongly about this type of visit as well. And now with some of the AI tools that we have, it's making it even more possible. In ophthalmology specifically, we have, FDA approved now tools for diabetic retinopathy, macular degeneration, glaucoma. But here's the really interesting thing, a new FDA approval for cardiovascular risk assessment through a retinal exam or through a retinal picture, and biological age as well. So as we move towards more preventative care, this is really important. Okay, these are all the codes that we use. Again, I'll share all of this stuff so you'll have it. and use telemedicine because only actors smile in waiting rooms. All right, that's it.
That is an amazing, Dr. Habash, that's an amazing presentation. I want to commend you for your bravery to go ahead and say some of the things that I know a lot of providers wanted to know about, but maybe we're too afraid to ask. I know we're going to get some questions. I know there's a few residents that are about to jump off. I'll say this, there's a bad misinformation field around telemedicine. I cannot tell you how many providers I hear tell me, oh, I would do telemedicine. It's too bad you don't get paid for it anymore. And I know that's not true. And we hear that all the time. And we're like, no, you do get. So I'm appreciative that you included that. I know it kind of feels like, well, why are we including that? That's the one part of telemedicine I feel like makes people, or it kind of shuts them down a little bit. Is they always feel like, oh, I would do it, but I don't know how to get paid for it because I'm not, it's not all that difficult. It's a little different and you can learn it. And the other thing I love to see is the other misconception I often see is providers will say, well, I need to be all telemedicine or all in person. And you showed a great model where you can mix it up and you found ways to make it successful for you and your practice. And I think that's the other thing is, you all have went through probably a lot of iterations and you learned the hard way what does and doesn't work for your practice. And I love that y'all are willing to share that and you're willing to share knowledge because that knowledge you're sharing is there to help providers do a better job and help patients get better services. And that's really commendable that y'all are so willing to share that with everybody who is here today and all the people who hopefully will be able to watch this video later.
Yeah, that was exactly the intent. We don't want you to have to reinvent the wheel. And we did want to kind of, address some of those misconceptions. So, like I said, if you do the work, you deserve to get paid for it. And so I think it is important to highlight, how you get paid and, how you use these rules.
Does anyone else have any questions in the chat? Looks like I don't see any there. Are there anyone else that's still on that has any chats or anything they'd like to say?
They're stunned silent, huh?
They're shy. It's a very shy Friday. I get it.
I know everybody's busy.
You're a hard act to follow. You just did a great job. We appreciated having you.
I will say really quickly, actually prior to this presentation, I was thinking, because I've shadowed a few ophthalmologists and I was thinking, how can patients with like retinopathies or like glaucoma, benefit from this? And then I just learned today from you that there's technologies where you can take the IOP pressures, you can take the FA images, and I'm thinking in near future, they're probably going to take OCT images as well. So you'll have everything. That's great. It's kind of like, it's really an eye opener for me that, you just have everything and it's so quick.
Yeah. Eye opener is a good pun. Is that
I noticed that too. Way to go with that pun. Yeah, no, you're right. And actually there are some, I didn't want to get into like names of companies or anything like that, but there are companies that have, there's a company named TopCon. I have no financial interest in this. I don't get behind anything that I don't believe in anyway. So just so you all know that, but I have no financial interest in TopCon at all, but they have a dual camera that's a fundus photo that takes a fundus photo and has an OCT on it, both at the same time. And this is an automated camera, and they have the coolest instructional video because it has like a 6-year-old child who says, "Okay, we're gonna do your now." It's literally one button. And so that's actually really important because you don't need a trained technician to do this stuff. It can sit at like a retail pharmacy, for instance, or an outreach facility, or, a campus anywhere. And you don't need that specialized like ophthalmic technician to do anything. So glad
that's really inspiring.
It is. Yeah. And I mean, it's more efficient that way because a lot of times there are times where we're retaking the pictures. At least I've seen retake of pictures just because, it wasn't the best one. So it's pretty efficient.
Yeah, our reading rate when we I showed you kind of the screening that we had done too. I think it was like 0.02% or something. I mean, really small number that weren't readable. These cameras are getting really good, and this is like undilated too.
Oh yeah, I was gonna ask. So does it account for dilation?
Need to dilate unless patient has a really small pupil or some other issue. Yeah. Otherwise, no, they're made automatic and non-mydriatic.
That's cool. That's really cool. All right, well, thank you so much for the great presentation, Dr. Habash.
My
To the
pleasure.
audience, don't forget to fill out the session evaluation survey to obtain your CME ethics credit. You can access the survey by scanning the QR code on the screen, and a link to complete today's session evaluation will be emailed to all participants as well. We will now open the floor to any further questions, if anyone has any.
I think we have some shy people, but in the spirit of trying to get things done, thank you for such a fantastic presentation and discussion. And to everyone who joined us today, to Dr. Stewart, who provided the citations in the chat, our wonderful team who makes the series possible. We'd like to present you, Dr. Bash, with the prestigious TexLa TRC Challenge Coin for a wonderful webinar today.
Oh,
Obviously,
wow.
the one you're seeing is virtual, but we're going to be sending you one in person, as well as for your pioneering contributions to advancing ophthalmology care and healthcare in general. It was very wonderful to meet you and have you with us today. Be sure to join us for our next presentation, Thursday, December 7th, with Dr. Brian Wood. More information about the registration link will be available on our website and social soon. Thank you again for joining us, and have a great rest of your day.
Thank you so much for having me, guys. And you've got my contact information. If anybody wants to reach out, you want more information, please do so anytime. So happy to help.
And then also anything that you can do in telehealth to prevent people from having to fly into Miami Airport, probably all the better, you know.
Okay, touche.
Have a great day.
Plus, it's like January, right?
Yeah.
Thank you all. Bye-bye.
She was great.